Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your on-the-go source for radiology board review. On this episode, I will be discussing tumors of the head and neck. This is a topic that has been requested by multiple listeners, and I am excited to be able to bring this to you because I do consider this high yield for radiology board review. I do anticipate that this will be a multi-part series, and after I have released the episodes on head and neck cancers, I will make a free downloadable study guide available on my website, theradiologyreview.com. I also have other free downloadable study guides available on my website. So if you haven't yet, go ahead and check out my website, theradiologyreview.com. With that being said, let's get into the questions and answers for part 1 of my review of head and neck cancers. First question. Esthesioneuroblastoma, that is ESTHES, esthesioneuroblastoma are neuroblastomas originating from what type of cells? The answer is that esthesioneuroblastoma arise from olfactory cells. Next, esthesioneuroblastoma classically have a dumbbell-shaped appearance. Where in the head and neck is each part of the dumbbell located? An esthesioneuroblastoma typically starts at the cribriform plate, and that makes sense because these are olfactory cell in origin, and that is where the waist of the dumbbell typically would be. So the waist of the dumbbell shape that is common for esthesioneuroblastoma is at the cribriform plate. One end of the dumbbell would then extend upwards through the skull base into the inferior intracranial vault, and the other end of the dumbbell would extend inferiorly into the sinuses. The classic imaging appearance of an esthesioneuroblastoma that I think you should keep in mind for board review is a solid enhancing mass at the cribriform plate extending upwards into the brain, with a large cystic and solid component and an additional solid inferior component, that inferior aspect of the dumbbell that extends inferiorly into the sinuses. Next, an esthesioneuroblastoma typically presents at which age? The answer is that esthesioneuroblastomas have a bimodal age distribution. It is typical for an esthesioneuroblastoma to onset around age 20 and also at around age 60. So there is a bimodal age distribution, roughly age 20 and age 60, in terms of common ages when you may see onset of an esthesioneuroblastoma. Next question. Which nuclear medicine studies classically would show uptake within esthesioneuroblastomas? Esthesioneuroblastomas are often somatostatin-positive lesions, so you would expect uptake on an Indian 111 octreotide scan and a gallium-68 dotatate PET-CT scan. Note that FDG PET-CT has a lot of intracranial uptake from the FDG, so there is some early data suggesting that gallium-68 dotatate could be useful for evaluation of esthesioneuroblastoma because gallium-68 dotatate does not have high intrinsic brain uptake like you see with FDG PET-CT. On an FDG PET-CT, an esthesioneuroblastoma would typically be expected to show uptake similar to that of the brain, and therefore the signal-to-noise on an FDG PET-CT for esthesioneuroblastoma may not be as good as the signal-to-noise that you would expect on a gallium-68 dotatate PET-CT. Next, what are the top 2 most common locations for a chordoma. That is chordoma. What are the top 2 most common locations for a chordoma? A chordoma originates from the notochord, so these can present anywhere from the skull base to the sacrum. The number 1 most common location for a chordoma is actually within the sacrum, and the number 2 most common location for a chordoma is within the clivus. So remember that clival chordomas are common in terms of locations for a chordoma. Chordomas are typically T2 bright lesions, and chordomas can have something called the thumb sign, which occurs when a chordoma projects from the clivus posteriorly and indents or has mass effect upon the adjacent pons. That can be called the thumb sign. Next, the top differential consideration for a chordoma of the clivus is what? The answer I am looking for is a chondrosarcoma. However, compared to a chordoma of the clivus that is typically at the midline, a chondrosarcoma of the clivus would typically be lateral to the midline. So you can potentially use that to help you on a board exam. A midline mass involving the clivus may be more likely to be a chordoma, whereas a slightly lateral off midline mass may be more likely to be a chondrosarcoma of the clivus. Next question. What entity should you think of first if you are given a clinical history of the following? A male teenager with frequent and severe nosebleeds, and you are shown an image of a very vascular mass that is centered at the sphenopalatine foramen that also expands the pterygopalatine fossa. Go ahead and rewind that to listen to that again if you need, but I have given you a fairly classic description for a certain entity. Can you think of what that entity is? The answer I am looking for here is a juvenile nasal angiofibroma. So clues that should get you to think about a juvenile nasal angiofibroma include a male teenager with frequent and severe nosebleeds, an image of a very vascular mass centered at the sphenopalatine foramen region, and imaging that shows that the mass expands the pterygopalatine fossa. Those are all things that, especially together, point to the possibility of a juvenile nasal angiofibroma. Next, what is the primary vascular supply of a juvenile nasal angiofibroma? The answer is that the ascending pharyngeal artery or the internal maxillary artery may serve as the primary vascular supply of a juvenile nasal angiofibroma. These masses tend to be very vascular, so you would expect a very prominent blush on angiography and the corresponding history that we went over on the preceding question. Next, and this is a bonus question. What is the main arterial supply on an angiogram to evaluate a posterior nosebleed? The answer I am looking for is the sphenopalatine artery. Note that if you are going to treat with embolization for a posterior nosebleed, you need to make sure that there is no variant anastomosis with the ophthalmic artery, as you absolutely do not want to embolize the eye for obvious reasons. So whenever you are shown an angiogram in the setting of a posterior nosebleed, always look for vascular collaterals to the ophthalmic artery, and be aware that non-target embolization of the eye is a complication that is best avoided. Next, what is a leading cause of posterior nosebleed that does not present with a mass, but rather presents with multiple arteriovenous malformations, which I will abbreviate as AVMs, arterial venous malformations? The answer I am looking for here is a very high-yield entity for the ABR core exams, and that is Hereditary Hemorrhagic Telengiactasia, sometimes abbreviated HHT, Hereditary Hemorrhagic Telengiactasia, which is also known as Osler-Weber-Rendu syndrome. Classic on board exams would be a provided clinical history of recurrent nosebleeds and a picture that shows telangiectasias of the face and hands. The most common sites of AVMs would be the nose, the skin, and the liver, but AVMs may also be seen elsewhere to include the lungs and GI tract. Remember that HHT is an autosomal dominant disease, so you could expect a family history in a question stem. Clear as mud? If not, I encourage you spend some time to review Osler-Weber-Rendu syndrome, which is also known as Hereditary Hemorrhagic Telengiectasia. Next, what should you think of first if you are shown a maxillary sinus mass in a 30 to 40-year-old patient that enlarges the maxillary sinus ostium and extends into the nasopharynx without bony destruction? What I have just described is a classic description for an antrochoanal polyp. That is ANTROCHOANAL, antrochoanal polyp. And a buzzword for an antrochoanal polyp is a mass that causes non-destructive widening of the maxillary ostium. Next, what is the classic location of an inverting papilloma? The answer I am looking for is the lateral wall of the nasal cavity. Note that an inverting papilloma is often a cause of focal hyperostosis that is subsequently trapped within the mass. And let's continue on to the next related question. What is the classic MRI appearance of an inverting papilloma? The buzzword for the MRI appearance of an inverting papilloma is a cerebriform pattern. That means a brain-like pattern, cerebriform pattern. And it is called this because an inverting papilloma appears similar to brain on both T1 and T2 weighted MRI sequences. Next, approximately what percent of inverting papillomas harbor a squamous cell carcinoma? This is a common test question that can come up from time to time, so make sure that you know that about 10% of inverting papillomas will have an associated squamous cell carcinoma. This is a risk that you should be aware of for test purposes, that an inverting papilloma does have about a 10% risk of harboring an additional squamous cell carcinoma. Next, what is a SNUC? That is SNUC. What is a SNUC, and where is the most common location of a SNUC? SNUC. The first part of this question, in terms of what a SNUC is that SNUC is short for a sinonasal undifferentiated carcinoma. The most common location of a SNUC is in the maxillary antrum. Remember that a SNUC is more aggressive and has a worse prognosis compared to garden variety sinonasal squamous cell carcinoma. Also, SNUCs often present as a large, mildly enhancing, fungating mass with ill-defined margins. Next question. Sinonasal lymphoma is most common in what age group? In general, sinonasal lymphoma is most common in the greater than 60-year-old age group. We are considering older adults in terms of sinonasal lymphoma, and sinonasal lymphoma tends to be more common in the nasal cavity compared to the sinuses. Next question. If you are shown a cystic structure at the floor of the mouth that looks like a sack of marbles, and on imaging you see multiple fat lobules within fluid, what is this classic for? I've given you somewhat of an ant mini description here. Cystic structure at the floor of the mouth that looks like a sack of marbles, and maybe you see multiple fat lobules in fluid. This should make you think of a floor of the mouth dermoid or epidermoid cyst. Note that location at the floor of the mouth and presence of internal fat would make a dermoid cyst more common than an epidermoid cyst, but these often can't be differentiated on imaging, so just remember this appearance is classic for a dermoid or epidermoid cyst. Next question. What do you call a large mucus retention cyst that arises from the sublingual space and extends inferiorly under the mylohyoid muscle? The answer I am looking for is a plunging ranula, R-A-N-U-L-A. A plunging ranula is a large mucus retention cyst that arises from the sublingual space and extends inferiorly under the mylohyoid muscle. Next. In a young adult with a new mass in the left cervical level 2 region, what malignancy do you need to exclude first? The answer generally is a squamous cell carcinoma, but more specifically would be an HPV, human papilloma virus-related squamous cell carcinoma. An HPV-related squamous cell carcinoma often presents as a large necrotic node in the cervical level 2 region. This can look very similar to a brachial cleft cyst, but squamous cell carcinoma must first be excluded before you really consider the possibility of a brachial cleft cyst. I think that is enough for the first episode on head and neck squamous cell carcinomas. Stay tuned. I will be releasing another episode that will be reviewing things like paragangliomas and salivary gland tumors. Feel free to reach out to me with any comments or questions or suggestions for podcast episode topics. Please know if you have already sent in a topic and you have not heard that presented yet, that I am working on these. I do take every request into consideration, and I believe in due time I will provide an episode for most, if not all, of the requests that come my way. Also, a plug that I am posting nearly daily, a short tip typically pertaining to physics, at least currently, on Twitter at RadRevPodcast. So if you haven't found me on Twitter yet, please go ahead and do that. I also want to send a plug out there that if there are free online radiology board review resources that you have found useful, please reach out to me and let me know, and I will check it out and consider sharing that with my audience either on the podcast or through my website. I also have a list on my website, theradiologyreview.com, of certain free online radiology websites for board review or radiology education that I have found useful. I hope these episodes have been helpful for you. Keep up the good work. Keep learning. Study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.